Good morning, everyone. Thank you, Tarjini, for this opportunity. So, in the next few minutes, I will be taking you through my through few cases and my rescue measures in each of these cases. First, I will begin with eyelid tumors. So, this particular girl, 6 years old, had come to us with a right eye ocular surface squamous neoplasia with an intraocular extension. You can see we had to do enucleation, and that's a customized ocular processes in the right eye. But the problem we were constantly facing was the multiple crops of squamous cell carcinoma on her face, because this was a patient of xeroderma pigmentosum, and multiple times skin graft has been done, and as you can see from the edges of the skin graft area, new lesions were cropping up. So in this particular case, we resorted to imiquimod once daily for 2 months, and this is after 2 months. It was taking care of all the squamous cell carcinomas which were cropping up. So topical imiquimod is a good option for multiple superficial squamous cell carcinoma and basal cell carcinoma. Apart from this, there are other options like 5-fluorouracil, photodynamic therapy, and targeted therapy. Worldwide, Bismodegib and Sonidegib has come up uh, as a great medication for unresectable or metastatic basal cell carcinoma, but in our country the use is limited because of the expense and the fact that there is recurrence on stoppage of the medication. So, neoadjuvant chemotherapy for eyelid tumors, earlier for sebaceous gland carcinoma with orbital extension, the only thing in our armamentarium was performing an orbital exenteration, but now that is not the case. Like you can see for this sebaceous gland carcinoma with the orbital extent, there's a fairly established protocol for neoadjuvant chemotherapy using cisplatin and 5-fluorouracil 6 cycles, where we chemo reduce the tumor size, and following which um, conservative eyelid sparing surgery is possible. So chemo reduction helps in performing conservative surgery in extensive sebaceous gland carcinoma. MAP biopsy earlier, as you all know, pagatoid spread can happen in sebaceous gland carcinoma. Earlier, we used to do MAP biopsy only in cases where there were clinical indicators like diffuse conjunctival congestion, thickening of eyelid, loss of meibomian gland architecture, loss of eyelashes, surface telangiectasia. Then only we used to go ahead with MAP biopsy, but recent literature from our institute shows that we will miss 10% of pagatoid spread if we just base on clinical diagnosis. So, MAP biopsy should be ideally performed in all cases of periocular sebaceous gland carcinoma. So, post-operative protocol for eyelid tumors is of absolute importance. It is not just about excising the tumor. We need to look in the histopathology report. We need to look for risk factors like perineural, intraneural invasion, vascular emboli, and if they are present, we need to consider radiotherapy. Fixed frozen mismatch can happen, and in literature reported to be around 2 to 10%. So post reconstruction, if you see the margin is positive, in lamellar cases consider cryotherapy. For full thickness cases, external beam radiotherapy is required. Similarly, for MAP biopsy positivity, based on the number of sites which are involved, topical mitomycin C, cryotherapy, and for diffuse involvement, exenteration is the treatment. Regional lymph node metastasis, all cases are local lymph node examination needs to be done, and if it is positive, FNSC needs to be done, diagnosis to be confirmed, and radical node dissection and radiotherapy needs to be considered. Moving on to ocular surface tumor, nodulo-ulcerative OSSN is a very rare form of OSSN, but very aggressive. I will like to take you all through this particular case of a 28-year-old gentleman who presented to his ophthalmologist and was diagnosed as a case of limbal stem cell deficiency post chemical injury. He was started on topical steroid. This is at day 21. You can see there is a sterile scleral melt. His ophthalmologist performed a scleral patch graft, which eventually melted, and on day 28 he was referred to our ocular oncology clinic. So this is a typical case of nodulo-ulcerative OSSN. You can see the localized area of conjunctival and scleral dehiscence. Focus on the on the conjunctiva surrounding it, you can see that it is indurated, has these feeder vessels, and there is usually a corneal haze in the surrounding cornea. So the patient was advised extended enucleation at this stage, but he refused because the vision at that point of time was 20/25, and you can see what has happened at 10 months. The mass is engulfing the entire globe, the orbit. This is at 2 years, and we lost him after this. So this was a seropositive patient with nodular ulcerative OSSN, so localized ulceration of conjunctiva sclera tarsus surrounded by indurated thickened conjunctiva. Think of nodular ulcerative OSSN, and an extended enucleation will be your rescue measure in such cases. So laser photocoagulation of conjunctival, benign conjunctival tumors is also something coming up. Like we have a protocol of doing a laser with the help of a yellow laser photocoagulation. And this is how visual changes happen. So this was the first patient we had done in an anophthalmic socket for a patient of nevus. And it first becomes, the visual change is graying, followed by cavitation, blackening. At this stage, it can nicely be removed with the help of a bud. So this is a patient you can see without any scarring or tissue dragging, which are cases for such big tumors. In cases of surgical excision, the tumor has resolved. Plaque brachytherapy for conjunctival tumors. This was a typical case of a leiomyosarcoma conjunctiva. You can see the vascular tumor with blood vessel dragging. This is on UBM. So post-excision, plaque brachytherapy needs to be considered for all such malignant lesion to decrease the chances of recurrence. Similarly, for OSSN, of all cases where there is a base involvement, look, like this particular case, you can see there was scleral fixity on clinical examination, and on UBM it shows that the anterior scleral fibers are involved. We did a lamellar sclerectomy, but that needs to be followed up. You can see the base positivity on histopathology, so it needs to be followed up with a plaque brachytherapy. So this was a secondary plaque brachytherapy, but plaque brachytherapy can also be considered as a primary treatment. Moving on to orbit. Bleomycin sclerotherapy. So this 12-year-old girl with an acute exacerbation of her URTI presented with this picture. So on CT scan, you can see the ill-defined multiple cystic masses, which is transcompartmental with multiple air fluid level. This is nothing but a venolymphatic malformation, and aspiration of the blood with bleomycin sclerotherapy is the treatment of choice, and this is post-op. So sudden intraorbital hemorrhage in a child, think of a venolymphatic malformation and consider bleomycin sclerotherapy. This 57-year-old lady presented to our clinic with this inferior palpable mass. There was choroidal folds, tortuous vessels. In MRI, you can see the multiple flow voids, the huge vessels which are there all around. So we reviewed the previous record, and what came up was that the patient has already undergone an orbitotomy with torrential bleeding. The surgery was abandoned despite attempt by the surgeon using everything possible. The surgery was abandoned, and on incision biopsy, this was a case of a solitary fibrous tumor. So we have a hypervascular solitary fibrous tumor causing mass effect. We know that there has been an attempted surgical excision which can cause a malignant transformation and increase chances of recurrence. So what were the options? Options were two, either a radiotherapy or an embolization. We chose embolization because it is more targeted, saves time, and immediate surgery can be performed. So this is the embolization, where we embolize the feeder vessels, and you can see the vascularity of the tumor coming down, and we perform the surgery after 1 week, and the tumor could be taken out in toto, and this is at 5-year follow-up. So preoperative embolization in collaboration with your interventional radiologist is a safe and effective procedure for reducing vascularity in vascular tumors like SFT or alveolar soft part sarcoma. So as was being mentioned by Stephanie, you should always be very proactive in publishing your complication. This was one such patient. It was an uneventful surgery, an intraconal mass, just a cryo extraction by an inferior transconjunctival approach. But on day 1 post-op, there was no PL vision, and it was an ophthalmic artery occlusion which happened. So keeping this in mind in this context, I will like to discuss this 39-year-old lady who came to us with both eyes, best character visual acuity of 2020, but she complained of a mild blurring in the left eye. And you can see this enhancing small mass lesion sitting on her optic nerve, causing this disc edema. So there is a lot of literature that talks about stereotactic radiotherapy for such cavernous hemangioma. So stereotactic radiotherapy has made it very safe these days. Proton beam radiotherapy will be the best option, but the availability is an issue, and also it's very expensive. So earlier days there used to be invasive BRW frames for fixing the head of the patient. Then we moved on to non-invasive GTC frame, but at present the brain aquaplast, which is nothing but just a cover on the face of the patient, and the onboard imaging, things are easy, and precise localization of the tumor can be done with no incision, no anesthesia. So this is what we did for our patient IMRT, and this is post IMRT. You can see that the widening of the blind spot and the superior field defect which was there has come down, and this is the optic disc edema has also resolved. So for apical tumors, intraconal tumors, stereotactic radiotherapy is a great option. You need to have a good rapport with your radio-oncologist. And this was my rescue measure for this particular patient. So combined orbital and endoscopic approach needs to be considered for all cases of orbital tumor with or a sinus tumor with orbital extension, like we did for this particular patient, non-keratinizing squamous cell carcinoma of the maxillary sinus. Moving on to intraocular malignancy, intraarterial chemotherapy, the advent in late 2000, this has been again a game changer. It is an established technique, though expensive for us. Globally, it has become the standard of care, but for us, we reserve it for refractory cases because of the expense. However, it does not take into consideration the systemic micrometastasis, and the complications can be devastating if not done by experienced people, like ophthalmic artery occlusion. So this is the protocol. We use a 3-drug regimen, topotecan, melphalan, carboplatin. This was the first we did in our part of the country, and what I want to emphasize here is it's a collaboration between the interventional radiologist and your pediatric oncologist. And I will skip the technique there. So we basically go in through the femoral artery, and it's a super selective ophthalmic artery. We go to the ostium of the ophthalmic artery, and the drug is delivered there. So this was a primary IAC post 3 cycles complete resolution. Intravitreal chemotherapy, again I will skip the procedure there. So earlier the traditional teaching has been we should never go inside an eye with retinoblastoma, but again a game changer there. Nowadays we take care of the vitreous seeds with the help of intravitreal chemotherapy. We have a protocol for safety enhanced intravitreal chemotherapy where we choose cases where the retinal tumor has been taken care of or it has become smaller, so that we have a safe area surrounding the aura where we can go in without puncturing the tumor. So choose a safe side, use a thin gauge needle, preferably a 30 gauge needle. The exit should be through a ice of cryotherapy, and we need to inject the site. A triple freeze thaw cryotherapy needs to be done. Death by water, you just flush the area of the injection with the help of distilled water to flush away the tumor cells. You can also raise a bleb of subconjunctival topotecan at the injection site to take care of any tumor cells there. Earlier we used to use intravitreal melphalan, but the complications were higher, and the major concern was retinal toxicity. There were pigmentary retinopathy happening in all such patients. Now we have moved to intravitreal topotecan, which doesn't have retinal toxicity, and the efficiency is more. So this particular girl, 2-year-old, the left eye was enucleated because of group E retinoblastoma. Right eye, this is the only seeing eye of the patient. We had already done 12 cycles of high dose intravenous chemotherapy and also orbital EVRT. She presents back with a tumor recurrence. What do we do now? So intraarterial chemotherapy was our rescue measure. Again, after 3 cycles of intraarterial chemotherapy, she has some residual vitreous seeds. We resort to intravitreal chemotherapy, 2 cycles, and this is after complete regression. Now we have performed a cataract surgery, and 3 years post-op, the patient is doing well with a vision of 20/40. Intracameral chemotherapy is the new kid on the retinoblastoma block, but the case selection is of utmost importance. So this is the last case where again a patient of retinoblastoma, you can see the orbital implant it has migrated into the inferotemporal quadrant. The implant exchange was performed twice, and it was seen that the implant is moving back to the inferotemporal quadrant. So the options in hand were implant removal and with a dermis fat graft, or a customized orbital 3D implant that we performed. A 3D implant was made and it was placed in the inferotemporal quadrant so that the PMMA implant was pushed up, and this is the patient doing well. So we discussed in eyelid the rescue measures as targeted therapy, neoadjuvant chemotherapy, map biopsy, a strict post-operative protocol. In ocular surface, diagnosis nodulo-ulcerative OSSN appropriately and performing enucleation, laser photocoagulation for benign lesions, mostly larger lesions for a scarless outcome, plaque brachytherapy, bleomycin for VLM, preoperative embolization for vascular tumors, radiotherapy for intracorneal apical tumors, and a combined orbital and endoscopic approach whenever there is a sinus extension. For intraocular tumors, intraarterial chemotherapy, intravitreal, intracameral chemotherapy, using appropriately customized to each patient, 3D printing of orbital implant. Thank you everyone for patient listening.
Thank you very much.